Welcome everybody. My name is Karla Seaman and I'll be presenting to you today on using linked data to explore the association between statin medicine adherence and hospitalisation following a large co-payment increase. I completed this as part of my PhD candidateship for the School of Health Sciences at the University of Notre Dame in Fremantle, Western Australia. So medication co-payments in Australia. So medication in Australia is subsidised under the Pharmaceutical Benefit Scheme, and residents make a contribution, co-payment, towards their cost of the medicine. The PBS helps to manage costs through ensuring appropriate use of medication, deter wastage, and help to maintain a sustainable health system. There are two types of beneficiaries. There's general beneficiaries who pay $41 per script co-payment, and concessional beneficiaries who pay currently $6.60 per script co-payment. There's also something called a safety net, and this is based on the calendar year and for a family contribution. And once the family contributes the co-payments to the tally of for generals $1,486.60, their co-payment amount decreases down to the concessional value of $6.60 till the end of the year. And then for those who are concessional payments, once they reach the safety net tally of $316.80, their co-payment becomes free till the end of the calendar year, where the amount then resets. Co-payments increases in Australia have increased each year in line with the Consumer Price Index. It's increased incrementally over the last 2 decades. However, on January 2005 was the largest observed co-payment increase within Australia, and this was from a 21% increase, which was for concessionals $3.80 to $4.60, and generals $23.70 to $28.60. In addition to this, the safety net amount also increased as well. When we know that sharp increases cause potential concerns about affordability for consumers. So my study focuses on HMG-CoA reductase inhibitors, so statin medications, and this is because previous research has indicated this subgroup were affected by the 2005 co-payment increase in Australia. They are an essential asymptomatic medication, and the consequences of discontinuing are potentially serious. Primary prevention reduces all-cause mortality and cardiovascular events, and secondary prevention reduces the risk of a further cardiovascular event and death. Hence, there is potential for a disruption in statin use as a result of a co-payment increase making medications less affordable to adversely affect health, such as acute coronary syndrome and stroke, which could result in additional hospitalizations. Hence, my study was aimed to explore the 2-year risk of acute coronary syndrome or stroke-related hospitalization among individuals who discontinued or reduced or continued statin medication after the 2005 PBS co-payment increase. This was a retrospective observational study of whole population administrative Commonwealth and state data sets. This included PBS pharmacy claim data, the Western Australian hospital morbidity data collection, so your hospital data, and your mortality register, so your death data. It included individuals within the WA population data from 2002 to 2010, and the linkage occurred through the Western Australian Data Linkage system. The cohort consisted of a patient prescribed a statin medication, which was identified using the ATC codes, and those that were taking a statin medications, their respective pharmacy dispensing history also was included. For methods, the first thing we did was to identify who was a stable statin user in December 2004. So this was defined as those who had at least 60-day supply in the last 3 months or 150-day supply in the last 6 months of 2004. We excluded if they were under the age of 18 in 2004 or died before July 2005, as we felt death occurring shortly after discontinuation is unlikely to be a result of the statin discontinuation or reduction. And we also excluded those who had a medication possession ratio greater than 150% in 2004. We then calculated adherence levels for individuals classified as a stable statin user for 2004 and then for the first 6 months of 2005. We did this using the medication possession ratio as a proxy measure of medication adherence. Stable statin users were then classified as either discontinuing, so they had no statin medication dispensings in the first 6 months of 2005, reducing, so they had a 20% reduction in the medication possession ratios pre and post the January 2005 copayment increase, and continuing, a change in statin medication possession ratio adherence of less than 20%, or if they had a medication possession ratio greater than 80% in the first 6 months of 2005. The follow-up for this study was the 2-year period from July 2005 to June 2007, and the primary outcome was 2 years hospitalisation for acute coronary syndrome or stroke-related event. Analysis was conducted using fine and grey competing risk method with death as a competing risk, and further analysis was conducted stratified by age and sex. The ICD codes were used to identify the acute coronary syndrome using codes I20.0 or I21 and straight codes I60 to I61, 63 and 64. So in total we had 207,066 stable statin users in December 2004, of which 84% were continuing statin therapy at the start of 2005, 13% reduced statin therapy, and 3% ceased statin therapy. Looking at the demographic and clinical characteristics, those that reduced adherence or discontinued statin therapy tended to be younger, general beneficiaries, i.e. paying a higher copayment amount, took more medication, had less coronary heart disease or stroke history, and had a shorter history of statin use. Those who discontinued statins were also likely to discontinue at least 2 other medicines, and those who reduced statins were also likely to discontinue at least 1 other medication compared to those who continued therapy. In the total cohort, 2.1% had at least 1 admission to hospital due to acute coronary syndrome or stroke as a primary diagnosis during the 2-year follow-up period, and 1.9% of the cohort died in the follow-up period. The multivariate analysis demonstrated that ceasing statins increased the risk of hospitalisation for acute coronary syndrome or stroke-related events by 18% compared to continuing therapy. This was then broken down by age group and gender, and it demonstrated that the risk of acute coronary syndrome or stroke hospitalisation was greatest for males less than 70 years who discontinued statin therapy compared to those who continued. No difference in risk was found for women or older men who discontinued statins, and there was no observed difference in the risk of hospitalisation for those who reduced statin use compared to those who continued. The results also suggest that patients who discontinued statins may have discontinued other medication, increasing their overall risk of hospitalisation. There are some limitations. Firstly, we cannot confirm whether a causal relationship exists between the copayment increase and hospitalisation for acute coronary syndrome or stroke. Not all the discontinuation or reduction in adherence of statin may be attributed to the copayment change. The findings may not be generalisable to other medications or primarily symptomatic conditions, as symptoms may return when use is stopped, with consumers more likely to continue to take their medication. A small number of events will not be captured in the dataset, and the PBS dataset during the study period did not capture medications under the patient copayment. The implications for the study is that men less than 70 years who ceased their statin therapy had higher risk of acute coronary syndrome or stroke-related hospitalisation than men of the same age who continued therapy. The 21% copayment increase affected other medication categories, and future research should explore if individuals choose between different medication categories. Doctors and pharmacists may support patients financially by prescribing higher strengths of statins for pill splitting, prescribing or issuing generics. conducting a medication review, and providing information about concessional status entitlements and also the PBS safety net. Encouraging patients to collect prescriptions from one pharmacy to track their safety net status and actively engage with local pharmacists may help. And the findings really highlight the well-established overall importance of continued adherence to prescribed statin medication, and that discontinuing or reducing medication for non-clinical reasons, such as cost, can have negative consequences. I'd like to acknowledge the Western Australian Data Linkage Branch, the Department of Health Inpatient Data Collection and Register General, and the Australian Department of Health for providing the linked data sets used in the study. And these are the references. Thank you.